it is a great pleasure to be in this symposium, not just because of the title and the topic that is important, but also because of the fact that this is the first collaboration between the two societies that I currently represent or have represented in the past. So I'm currently the chair of the WGO Hepatology Interest Group, and I have been a member of the APASL Executive Council from 2006 to 10. So as it were, I have been on both sides of the fence, and it really is very, very heartening to see this, this collaboration coming together. It was Professor Sareen's idea when we met in the last Hepatology Interest Group meeting, and hats off to him that we have been able to put this together. Now, taking advantage of the fact that WGO has a large outreach, as was mentioned by our president, Dr. Naima Amrani, we have something like 120 member societies, GI member societies from all over the world. We thought we should do a little survey and get some real world information about what is happening in terms of the COVID-19 and hepatitis services. So I will talk about some bit of that survey, and then I'll talk about the immunization services and how that has been affected. So I have no disclosures which are relevant to the presentation. This survey we developed along with Professor Sareen's group developed this survey, and we put our inputs into it, and it was only released on the 19th of July. So we've had a very short time to receive the results and to analyze them. So this is a very rough cut. This work will continue, of course, and we hope that this will culminate perhaps in the largest global evidence that we have in terms of COVID-19's effect on the hepatitis programs. Already, we have 170 respondents from 89 countries across the globe. So this is truly a global representation. Questions related both to hepatitis B and C, but I'm just putting up the hepatitis B part because that is my topic. So let me go through this fairly quickly. So the first question was, has the COVID-19 pandemic changed your practice of diagnosis of patients with chronic hepatitis B infection? And there doesn't seem to be much change in that practice of diagnosis. Whatever people were doing before, they were continuing to do even after the pandemic started. There was a drastic change in some of these practitioners, but not to a great extent. The next question was, how often do you do a liver biopsy? Do you perform liver biopsy in the initial assessment of patients infected with chronic hepatitis B? This is the pre-COVID era. So about 60%, roughly 60% of people said they were not performing biopsies, and they were dependent on other non-invasive methods of diagnosis. This percentage increased to nearly 80%. So the 20% who were performing biopsies before were not performing biopsies in the COVID era, and that is sort of understandable given the fact that people have to go to the hospital, they have to have some interventions, and so on. So they were not doing biopsies. Do you start new chronic hepatitis B infected patients on treatment during the COVID-19 pandemic? And 70% said yes. All cases were indicated they would start, but some were a little hesitant, saying only in cirrhotics with severe flares they would start, and some said they will postpone in all cases. But by and large, the majority would start new chronic hepatitis B patients on treatment during the pandemic. How has the COVID-19 pandemic affected treatment continuation of patients already on nucleoside or nucleotide analog? And this is a concern. 30% of these patients had treatment interruptions, perhaps due to not being able to go and get the medications, or maybe not even having the money to buy the medications if they were doing this out of pocket. And this seems to be particularly severe in Africa. We have yet to analyze this on a regional basis, but we'll do that soon. But the major impact of this lack of treatment or discontinuation of treatment seems to have been in Africa. This was an interesting question. How often do you use pegylated interferon if no usual contraindications for treatment of chronic hepatitis B in the COVID-19 era? And about 40% were using interferon therapy still uh, uh, if uh, if this was otherwise clinically indicated and there were no contraindications. Even in the COVID era, they would be using interferon therapy. So that's a little bit interesting. Regarding screening and surveillance of HCC in patients infected with chronic hepatitis B in COVID-19 pandemic era, what do you follow? So the large majority continue to do their usual 6-monthly imaging plus minus the alpha-fetoprotein. Some delay it, some use only AFP and blood markers, but the majority will continue to survey their HCC, their patients for HCC infection, which is very good. Regarding family screening of HBV infected patients in COVID-19 pandemic area, what do you follow? Always ask to go to visit and get screening along with the patient, a small minority, just about 20-25%. Ask to go and get screening done at a nearby laboratory, or delay screening, at least 1/3 of these patients. They will delay screening the family until the pandemic is over. What is your assessment regarding the effects of the COVID-19 pandemic on national viral hepatitis B and C elimination programs in your country? And nearly 30% of these programs have continued to run, but the majority have either slowed down or may have considerably slowed down. Nearly 52% of these programs have slowed down from their previous pre-COVID era. What do you think the goal of viral hepatitis elimination by 2030 is still achievable considering the COVID-19 pandemic? And there are certainly optimists in this group who said 42% said yes, they think the goals are still achievable, but there is a significant number of people who would say no, and the others don't know. So about 1/3 would say no, the goals will not be achievable. What is your assessment of available research funding for HBV in your country or region during the COVID-19 pandemic? And needless to say, there has been significant decreases in the availability of research funding, or slight decreases. There's hardly been a significant increase during this time. Regarding research output in hepatitis B during COVID-19 pandemic, what is your thinking? Again, a significant decrease, not surprising because the funding is not there. And finally, what do you think regarding national immunization programs for HBV during the COVID-19 pandemic? About 40% said they're continuing as before, but a good majority said participation by the public is slow and delayed, or the program is getting downsized due considering social distancing and other restrictions. So the programs have been affected due to the immunization program, due to the COVID-19 pandemic. So what I thought I'd do is pick Pakistan as a low middle income country and see what has been happening here. And some of this is actually quite frightening. The first case of COVID-19 was reported in Pakistan in February 2020. Since then, immunization services have continued to decline. Full immunization coverage in children declined from 240 in January to 190,000 in April, and declined further until now, until June, when we had our so-called peak, although we're not sure, we might have another peak after this. From January to June, a 25% decline in the Penta-3 coverage. And remember, Penta-3 is the pentavalent vaccine, which is the third dose vaccine, which is given to infants. Between March and April 2020, around 700,000 children missed the Penta-3 vaccination. They just simply did not turn up. And all this is UNICEF Pakistan's data, so I think there is some validity to this. Antenatal care services declined from 537,000 in January to 345,000 in April 2020, which means what? Which means that the birth dose did not get given in these nearly 200,000 pregnancies just in the month of April 2020. Most importantly, Pakistan, remember, still is one of the very few countries where there are occasional polio cases. Almost 40 million children missed out on their polio drops during this period from February to July. And the main reasons that have been cited were restrictions on movement and concerns around the COVID-19 transmission, so that people just simply did not want to present to healthcare facilities with their young infants or young children. This is some data from the, and pardon that this is in a slightly messy form, but this is what we get for the programs. This is hepatitis B immunization rates from the hepatitis control program in the province of Sindh, which is where we are. It's a large province, about 60 million population. In February 2020, just before the pandemic hit, they were doing about something like 16,000 first dose HBV vaccinations. This dropped to 2,437 in June 2020. And similarly, the number of cases registered, both for hepatitis C and hepatitis B, have significantly reduced over a period of time. This is from the largest province that we have, the province of Punjab, population around 110 million. And these are immunization rates from their hepatitis control program. I think this is just one hospital. This is not the whole of the Punjab program. And if you just look at the right-hand side of the slide, that is the most telling number. So in January, they provided 2,601 people with hepatitis B vaccination. This dropped to 21 only in May and 224 in July. So it is nearly a tenfold drop of hepatitis B vaccination. This is adult vaccination. This is not childhood vaccination, by the way. What were we doing before this? Well, we were doing very well. We were this was vaccination was one of the parameters that the WHO would probably say that the world was on its way to meet the 2030 targets, even well before 2030. So 3-dose hepatitis B vaccination coverage in 2015 was considered to be around 84%. Of course, there were some lower, some higher regions, but on an average, 84% coverage, which was fantastic, and it would have really resulted in in meeting the goal well before the 2030 deadline. What happens now is a little bit of a guess. We were not doing very well in the birth dose vaccination, only 35% coverage overall, although some sections were doing extremely well. The Western Pacific, for example, was leading the way, as has just been pointed out by Dr. Jha, with China and others, really doing remarkably well. Africa still not off the baseline, or a little bit off the baseline, and other regions don't even really appear. Emro, for example, doesn't even appear in this. So we had a lot of things to do in the hepatitis birth dose still, and this will obviously take a hit. Now, just a few words about the hepatitis B vaccine. This is something that I don't need to talk to this audience, but anyway, over decades, we know that this is a very, very effective vaccine. The data from Taiwan, 60% decrease in the incidence of HCC, 70% decrease in mortality from fulminant hepatic failure, 92% decrease in mortality from chronic liver disease. And this has since then been replicated in many other parts of the world. Excellent safety profile, cost effective, particularly as part of a strategy to eliminate vertical transmission of HIV, HBV, and syphilis. It is effective in most people, not 100% of people. In healthy adults aged less than 40 years, the 3-dose vaccine, which is administered 0, 1, and 6, reduces a protective antibody response in approximately 30 to 55% after the first dose, and greater than 90% after the third dose. After the age of 40, there is a decline in response to a little less than 90%, and by the age of 60 years, 75% response rates. There are factors which are recognized as being leading to non-response, like smoking, obesity, some genetic factors, and immunosuppression. They are all associated with the lack of response to hepatitis B vaccination. The WHO recognized the importance of HCC and other HBV-related diseases as global public health problems, and therefore they reiterate the recommendation that hepatitis B vaccine should be included in national immunization programs. And by and large, it has now been introduced in most of the world, if not all of the world. A comprehensive approach to eliminating hepatitis B transmission must address prevention of infections acquired perinatally and during childhood. And we are hearing a lot about this at this World Hepatitis Day, with the new guidelines coming out just today, released, and then that Dr. Jha mentioned as well. Reaching all children with at least 3 doses of hepatitis B vaccine should be the standard now for all national immunization programs. So the emphasis now really is on the birth dose vaccine. All national programs should include a monovalent hepatitis B vaccine birth dose, ideally within 24 hours. Having said that, although effectiveness declines progressively the days after birth, even after 7 days, a late birth dose can still be effective in preventing horizontal transmission and therefore remains beneficial. All infants who receive the late birth dose give the first contact with healthcare providers at any time up to the time of the next dose of the primary schedule should be given that late birth dose. So there's really the ideal is 24 hours, but there's really no defined limit. So this is the schedule: birth dose delivered within 12 to 24 hours. WHO says within 24 hours, other guidelines say within 12 hours. The earlier the better, I suppose. And then there is this little bit of difficulty that many countries in the world are now doing this or have been doing this as part of their EPI program. So they do the first dose at 6 weeks, the second dose at 10 weeks, the third dose at 14 weeks. And this is in the form of the pentavalent vaccine, which contains 4 other vaccines given at 4-week intervals. Now, the difficulty is that this is what Gavi provides to many countries around the world. And it is only now that they have come around to the fact that birth dose vaccination should also be provided as a monovalent vaccination. And of course, there's a lot of adult catch-up vaccination with the standard 0, 1, and 6 months in many of these programs I just alluded. So what will happen, or what has happened, or what can be the strategy in terms of the COVID-19 problem? If the series is interrupted after the first dose, the second dose should be given as soon as possible, and the third dose at least 2 months after the second dose. Remember, when we were young, we were saying, okay, you've missed the series, go back, start again from 0. That is not the teaching right now. If only the third dose is delayed, it should be given as soon as possible, even though it may be a few months later. Doesn't matter, just give it, and that should be effective. This is just, I took a screenshot. This was just from the WHO symposium that was being held concurrently, almost 2-hour symposium. And I don't think you can read the slide well, but this is the potential impact of disruptions to hepatitis B vaccination programs during the COVID-19 pandemic. And the gist of this is that nearly 5 million young kids would miss out on the birth dose vaccination all over the world because of the pandemic. And these are the kids who will then become chronic, many of them, and will then be candidates for the development of HCC. So in summary, globally, there has been major disruptions in the care of hepatitis B patients, in some areas at least, with interruptions in medications, interruptions in their routine screening and routine care, and so on. Vaccination services, including hepatitis B vaccination, have been significantly affected. WHO estimates, as I said, that nearly 5 million infants will not get adequate HBV vaccination coverage due to the COVID-19 pandemic and may be potential candidates for HCC development later on in life. Infants and young children need to be particularly, therefore, targeted for catch-up hepatitis B vaccination whenever the opportunity arises. As soon as the coast clears, we should really be going after these infants and young children and trying to vaccinate them. The world was doing well with hepatitis B vaccination coverage, and we need to get back to that level quickly. Thank you very much for your attention.